Hello everyone, this is Rastogi Ayush from group LA21922. My topic for presentation is traditional and modern information on the esophagotomy, the resection of the esophagus, and the operation on the atresia of the esophagus, which is guided by Professor Zadni Priyani and senior teacher Gulliver Ajisaleev. Esophagus. Esophagus is a tubular structure about 25 cm long that is continuous above with the laryngeal part of the pharynx opposite to the 7th cervical vertebra, and it passes through the diaphragm at the level of 10th thoracic vertebra to join the stomach. Three parts of the esophagus are distinguished: cervical part, thoracic part, and the abdominal part. Also, the layers of the wall of esophagus includes mucosa, submucosa, muscle layer, and tunica adventitia. Esophagotomy. Esophagotomy is an incision into the lumen of the esophagus. Indication for esophagotomy. Indication for esophagotomy includes foreign bodies, strictures, esophageal perforation, esophageal rupture, esophageal diverticula, parasitism, gastroesophageal interception. General surgical principle of esophagotomy. Esophageal surgery is associated with a higher prevalence of incisional dehiscence than surgery on the other portion of alimentary tract due to several factors may contribute to high complication rate. That includes lack of serosa, segmental nature of the blood supply, lack of momentum, constant motion caused by swallowing and respiration, and tension at the surgical site during swallowing. Preoperative consideration for esophagotomy. Fluid electrolyte and acid base imbalance should be corrected before induction of anesthesia. Patient should be fasted for 12 to 18 hours before esophageal surgery. Perioperative antibiotics may be given to prevent infection of periesophageal tissues. Approaches to the esophagus. Approach to the cranial thoracic esophagus via lateral intercostal thoracotomy at third or fourth intercostal space. Approach to the esophageal caudal thoracic esophagus at the heart base via right lateral thoracotomy at 8th or 9th intercostal space. Approach to the abdominal esophagus via ventral midline laparotomy. And approach to the cervical esophagus via midline incision of the neck. Post-operative consideration for esophagotomy. The patient should not receive food or water by mouth for at least 24 to 48 hours after surgery. Fluid should be continued until feeding resumes. Antibiotics should be continued for several days if the esophageal mucosa is severely eroded or lacerated. Analgesics may be necessary to control pain. Complication includes dysphagia, esophagitis, aspiration pneumonia, wound dehiscence, leakage at the surgical site, ischemic necrosis, stricture formation, and abscession. Now, the resection of the esophagus. Esophageal resection is a type of surgery in which a part of the esophagus or the entire esophagus is removed. The lymph node near the esophagus and stomach may also be removed during this operation. Indication for the resection of the esophagus. That may be carcinoma of the esophagus, high-grade dysplasia in the Barrett esophagus, destruction of the esophagus by caustic injury, esophageal dysfunction, scleroderma, eclasia, spasm, esophageal perforation, and recurrent gastroesophageal reflux. Approaches for the resection of the esophagus: upper midline laparotomy, right thoracotomy, left thoracotomy, left thoracoabdominal incision, left neck incision. Procedure. The procedure includes: first, the mediastinum is dissected along the anterior margin of left sternocleidomastoid muscle. The cervical part of the esophagus is retracted superiorly till the tumor is seen and the tumor is removed. Now, the operation on the atresia of the esophagus. Esophageal atresia is a congenital discontinuity of the esophageal lumen. It may be several types, according to the presence or absence of the tracheoesophageal fistula. Fistula is an abnormal connection between two body parts, as here we can see. Different type of esophageal atresia includes atresia with distal fistula. In this, upper part of the esophagus is having closed end and the lower part or distal part of the esophagus is connected to the trachea. Atresia with double fistula. In this, upper and lower part of the esophagus is connected to the trachea but do not connect to each other. Atresia with proximal fistula. In this, upper part of the esophagus is connected to the trachea but the lower part is having closed end. atresia without fistula. In this, upper and lower part of the esophagus do not connect and have closed ends. Preoperative management for the operation on the atresia of the esophagus. First, maintain the patient airway. Prevent aspiration of the stomach content or saliva into the lungs. Prone position to prevent stomach secretion from refluxing into the lungs. Intravenous antibiotics to help prevent the development of pneumonia. Procedure of the operation. Approach is made mostly through the right-sided thoracotomy at the level of fifth intercostal space. The azygous vein is divided by the ligatures. A catheter is pushed into the upper segment of the esophagus by the anesthetist to facilitate the isolation of the segment of the esophagus. The part which is connected to the trachea is transected, and end-to-end anastomosis is made between the two ends of the esophagus with the help of interrupted silk suture through all the layers, and a tube is passed through the anastomosis for feeding. It may so happen that the end of esophagus may not be brought together. In this case, the upper end should be brought to the surface of the left side of the neck above the clavicle, and a gastrostomy is performed for the feeding. Other methods for the operation of the esophageal atresia, that can be gastric pull-up, colonic transposition, and jejunum transposition. Now, let's watch a video to understand how the colonic transposition works in esophageal atresia. The colonic transposition is a method to repair the esophagus when it is either too short or damaged. In this method, we use a long piece of the colon to bridge the gap between the top of the esophagus and the stomach. Typically, this procedure requires two incisions, one in the abdomen and one in the neck. A long segment of the colon is carefully mobilized while preserving its blood supply. Then this segment is pulled behind the stomach into the chest to bridge the esophageal gap. Then the stapled portion are removed and the top of the colon segment is sewed to the esophagus. And then the bottom of the colon is then sutured directly to the stomach. And now here we can see the reconstructed esophagus. To help the stomach empty better, the valve at the end of the stomach is open. And lastly, we need to reconnect the ends of the colon. And finally, the blood flow is preserved to all segments of the colon. That's all for my presentation. Thank you everyone for your attention.